ARPI. So we kind of a consensus here that we should maybe use the triplets, chemotherapy, young, fit patients, high volume disease, visceral metastasis, and all these things. What about the ARPIs? I mean, we always have that question again. We don't have the comparisons, a lot of data over there, but no trial comparing.
Right.
Now we have the three, we call all the 4 ARPIs, but actually 3 androgen receptor, and then abiraterone, that is still standard of care, still there, still an option. How do you navigate with this? I mean, for the patient, as you said, I mean, it's overwhelming. Come with the patient, doublets, triplets, 4 different drugs, then to come to benefits and risks for every drug. I think it's a lot of information, and patients, like, it's not easy to digest. How you guys approach this, and maybe we can start taking some opinion about how to decide which of the drugs use which ARPI to use. Start?
I can start. Yeah, absolutely. I mean, for me, it always comes back to the patient, right? So you have to look at the individualized patient. What are their comorbidities? You know, what's their financial status? You know, how is their family support? All these things that go into it to make the decision. Like you discussed, all 4 of them have fairly equal outcomes. You know, there's a study looking head to head with abiraterone versus enzalutamide. Abiraterone did a little bit better in terms of outcomes there, but there's not great other head-to-head trials that are out there. And that wasn't even the trials, observational study. And so for me, I have to look at the patient and decide which of the 4 kind of works the best. I don't know how you guys manage it otherwise.
Yeah, I agree. It's really a conversation with the patient, maybe leaning a little bit more in their past medical history, like history of seizures, that will help you kind of dictate where you go, side effect profile, you know, cognitive impairment. But that's really kind of how I steer them.
Yeah.
And then also the other thing I think is important is, like, if they have an aversion to swallowing a lot of pills, sometimes the amount of pills you have to swallow on a day is also different.
Okay, yeah, because now we have different options with different pills that it can be easier for the patients. That's something to take into account, of course, and access sometimes.
Yeah, and some of them are dissolvable, some aren't. So those things do play a role.
Of course. Gordon, what about the you want to add something?
So I actually, just so I do agree. It comes down to an issue of you know, response, right?
Yeah.
So looking at survival outcomes, and they're all pretty comparable, right? Hazard ratios are all somewhere around the 37 to 47%, you know, risk reduction in death long-term for overall survival, especially when you adjust in certain trials. And then it's an access issue and a toxicity issue, right? Which is all what we're talking about here. But I do think it's worthwhile mentioning that there is some real-world evidence looking at, you know, which suggests there's a benefit in overall survival to APA compared to both ENDS as well as ABI. And I think that should be, you know, not that's going to necessarily make anybody's mind, but that data does exist. And this isn't, you know, I think when we talk about real world data, real world evidence, these are well designed trials with statistical rigor that, you know, have intensity, propensity, weight matching. That have a clear design and statistical endpoint. So I think that it should be viewed, you know, in that same light. It's validated by the FDA. So these trials are significant in their findings. That I think is up to the individual clinician to digest and understand, you know, how they view that in their treatment paradigm. But there is data to suggest that we may see better survival from certain choices.
Yeah, and if I can build on that, I'd like to. But as Gordon mentioned, like, you know, the Cures Act was approved by Congress and really gave the FDA a mandate to learn how to use real world data to create real world evidence. Those guidelines have come out, and, you know, as he mentioned, there have been 2 data sets coming out looking at API versus ABI and API versus Xtandi, and those results are out. And I think we as a community are going to have to learn, like, you know, how do we interpret and bring in all this evidence and help us make decisions in our clinic, because it's coming.
I think it's a bigger conversation around real world evidence in and of itself, right? Because historically, I think we have this, all right, single surgeon, single center experience,
series of cases,
but that's exactly not what we're doing.
Like,
right? We're looking at a well-designed, you know, statistically matched compared trial that is meeting the rigor of evidence that we would like for asking the questions that we're trying to ask, with a pre-specified statistical design with an endpoint. So I think it's important the audience take that away when they view real world evidence now. It's not your dad's real world evidence kind of situation.
Correct.
Historically.
Yeah, I fully agree that now the way that those studies are built nowadays are completely different than just like a series of cases that I have treated with like two or three drugs. It's a completely different scenario.
And I think we're getting closer. I think, with tumor subtyping, with better deciphered data, we're going to get better knowledge about maybe we can stratify patients based on their tumor genetics as to which choice is best.
And maybe this is, of course, we're always looking for the prospective, double-blind, randomized clinical trials, but at some point it's becoming complicated to do trials in some areas. To get the funding for those trials and to really do some other comparisons, it's becoming really problematic. So I think we should really invest in getting good real-world evidence. Do this comparisons, this matching. I think I really like to see this data.
That may be the biggest benefit of EMR.
Mm-hmm.
It's that we have, tracked outcomes for these patient populations that we haven't had.
Exactly. We need to take something from there. There's a lot of work. Exactly. What about the ADT? So it's coming back to not the ARPI. So let's go for easy question about the ADT. We have oral, we have injections, we have monthly, we have every 3 months, we have agonists, we have antagonists. So quite a few options as well for the use of ADT. Any preference for ADT, and especially any preference when you're using some ARPI? Let's say if I use this ARPI, I like this ADT, that's my doublet here. So do you have this kind of thing, or actually doesn't matter much?
My approach is not scientific at all. It's very much a smorgasbord.
No, this is real life again.
How it's going to fit in with the patient. Some patients are very adverse to injections, so having an oral agent now available is wonderful. Other patients, again, like they have pill toxicity. They don't want to take another medicine every day. And so then they like the injections. And then in terms of how often they're getting the injections, these patients are typically coming into clinic to see me every 3 months or my APP. So usually we're on the 3-month time point.
Yeah. For me, I think that it's very clear in the data that, using antagonists for the patients that have cardiovascular risk, that should be your choice. But then when it comes down to the nitty gritty of which medication you choose, again, patient selection, patient kind of counseling is what I need to do.
That's great. Any preference?
Yeah. I agree with what's been said already. I tend to go a little bit more frequent with antagonists than I do with agonists, for a variety of different reasons, especially in BCR or short course, or if we're looking at patients who have hormone-sensitive metastatic disease and they're on combination therapy. To me, they're going to be on that medicine for a long period of time. The safety signals that come through from the antagonists are a little more favorable to me. Mm-hmm. So I agree with you, wholeheartedly there from a cardiovascular perspective. But again, it comes down to access, and making sure we can get access, for our folks. There's always a concern around having to double the oral antagonist in the context of an ARPI. That's going to be on label in certain situations. There is some phase 2 data that exists, subset data from our ARPI trial, which demonstrated very small subsets. Demonstrates just a small initial signal that we may not need to do that. Obviously, that's not on label, but that's something that I think deserves further evaluation, in a bigger subset of patients, because pill toxicity is a real issue, right, for these folks. But I think I tend to lean a little bit more towards the antagonist when available.
Yeah, and I think at some point there is some signal that oral ADT and apalutamide could not be combined, and I just reviewed that actually couple of weeks to go after this question, and actually there's no problem in doing that, like that combination of oral ADT and apalutamide. We're expecting that, and we do have now good data to support that, of course.